Okay, so good morning, everyone. I'm Kat. I think everyone knows me by now. I'm going to be giving a talk today in our new ethics lecture series, which is a new lecture series for this year that Dr. Willis and I are kind of overseeing. And, you know, most of you know that I'm applying into a palliative fellowship. So this topic is really important to me. It's something I'm really passionate about, and it's something that I really want to encourage everyone else to think about while we, care for seriously ill and dying patients in the ER. So we're going to talk about death and dying today. Specifically, we're going to focus on how we care for seriously ill patients in the emergency department. So we'll focus on, or we'll explore cultural, ethical, and different systemic factors and discuss practical ways we can improve the experience for patients and their families, as well as for ourselves. I do want to recognize that, if you've recently lost someone, if you're mourning the loss of a loved one, this might be a little bit triggering, this might be a little bit difficult. And so, kind of trigger warning there. Feel free to take a moment, take some time if any of this becomes a little bit difficult, because, these are difficult topics. So I really want you to get away from this lecture, different cultural, systemic, and medical factors that shape the patterns of death and dying in the US, specifically looking at the ED. Identify the different ethical principles relevant to end-of-life decision-making in the ED, and understand why the ED is a critical and appropriate setting to explore goals of care with seriously ill patients. Now, I know I'm kind of preaching to the choir. I think most of us understand that this is important, exploring goals of care, having goals of care discussions in the ED. And then I know there's some who feel that this isn't really our role in the emergency department, which we're going to explore as well. But I'm hoping that I make the case today that this is an important consideration and something that I want you to think about in every patient interaction you have, particularly those with seriously or advanced stage diseases. So let's start with a case. I'm not sure I'm going to be able to see the Zoom chat, so if people can shout out, that would be more ideal. If someone can share what they see in the chat, I'm going to encourage some audience participation here. So you're in CCT or downstate, and you have an elderly 92-year-old woman come in from a nursing home. She has multiple comorbidities. She's bedbound, nonverbal at baseline. She has a chronic stage 4 sacral decube, and she presents in septic shock, acute respiratory failure, and acute renal failure, right? We care for patients like this all the time, particularly those from nursing homes. And so I would like to know what's your approach to this patient in the ED? What would you do? What are kind of like your first steps? Like, what are you thinking? What's your first approach?
I'd want to know a code status for this patient.
Right? Okay. And how do you do that in a patient who's bedbound nonverbal?
Hopefully they came with some paperwork.
Right. So what's that paperwork? Do we know?
Most form.
Most.
MOLST form, right? So most patients in nursing homes will come with a MOLST form. So hopefully the EMS brought it. Hopefully it's already maybe in the chart. What if they don't come with a MOLST form? What's your step?
And hopefully there's listed family.
Right. So how do you decide when there's multiple family members in the chart, how are you deciding who you're going to contact?
I feel like realistically it ends up being like whoever answers the phone.
Yeah.
But you should go by first the spouse, and then I mean in theory I think it goes by like the oldest child, but you don't know who's the oldest. So you call and then you ask the family who's going to be the next of kin.
Okay, yeah, so we're going to look more kind of at this process, but I think that's usually kind of the process we follow is whoever answers first. Actually, in New York, unless there's a healthcare proxy, which we'll talk about, all of if there's multiple children, all of them actually have to come to an agreement about what to do. It's not this like oldest. I used to think it was this oldest child thing, and it's actually not. So what about, I'm going to give you some scenarios. So let's say there's a son, whether he shows up, he's the only one in the chart, and you call him or he's there and he says, do everything, but there's no documented wishes for the patient in the chart. What would you do in that case?
Clarify what that means. What does it mean to do everything?
Okay, right, because that can mean different things to different people. Okay. And then what if he says, no, I want you to do everything, save her life, keep her alive. do you do that? Do you jump right to do that, or do you discuss it more, or
I think it
do you
sometimes
worry
it
if other
depends on
people?
what's going on. I
Right,
mean, there's always, there's always the idea of triage in terms of the ED. I think if you
right,
have the opportunity, availability to get into a longer discussion, great. If you don't, then that's, something that you have to figure out.
right.
And then I don't think the point of this presentation, but you can also engage in the thought process of futility, and that's
Yeah.
something you can decide as a physician as well.
Right. So, it's all very situational. And so that's really hard when someone says do everything, trying to manage the situation and what that means. What if the son says do everything, but the patient comes with a MOLST form that says that they want to be DNR, DNI, and comfort care? How would you handle that? What are some thoughts? Do you go with the son or do you go with the MOLST form? And these
It
are
would depend
they're
on
tough.
would probably depend on who signed the most form, right? If
Yeah.
it's a most form that the patient executed, then I would follow it. If it was by some other person that's not clearly the healthcare proxy, then I think I'd have to re-engage with the family who else is kind of differing from that.
Right. So that's another scenario. So the son comes and he says, do everything, but there's a healthcare proxy form in the chart that says someone else is a healthcare proxy, right? So, I mean, I bring up these scenarios because we have these situations frequently, right? And they're very ethically complex, they're emotionally charged, and they're just very common for situations we have in the ER. So I want you to think about some of these situations, and that's kind of what we're going to get into. So the thing about it is we're all going to die, right? That is one of the few things all of us have in common. It's inevitable, it's going to happen, right? Ben Franklin said taxes and death are the only certainties in life, right? So we all are going to die, and we're all usually going to care for someone who is dying. Yet we rarely talk about it. And so part of today's session is helping us confront this reality, not just clinically, but also personally and systemically, so that we can approach these patients who are facing the dying process or are seriously ill with clarity and compassion. So what's a good death? I just want to get some audience participation here too. Let's talk about the concept of good death real quick. What does a good death mean to you? Anyone want to share?
Gloriously in battle.
Okay, yeah, that's on par for Ola, right?
Not waking up.
Okay.
Minimal
Any
pain.
minimal pain, right? Okay. I think these are all things. I mean, we work in healthcare. We see people die from pretty horrible deaths a lot of the time. So I think all of us have a pretty good idea of what we think is a good idea of death. And I think we probably agree in a lot of that. But it's really important to note that the idea of a good death is very personal. It's very relative, right? It widely varies depending on culture, family, religion, and individual factors. It's not a fixed idea. It's fluid. It can change for a person what it means to have a good death. And what may feel like a good death for a patient might be experienced as difficult and traumatic by family or caregivers. And so this relativity is really important when we navigate these end of life care in the emergency department. And that's something to keep in mind. Although the idea of a good death is multifactorial, majority of Americans will agree that they prefer to die at home. This has overwhelmingly been shown time and time and again that majority would like to die at home, but in reality, few actually do compared to how many say that they want to. This is changing actually in recent years, which we'll get into a little bit later, but most Americans are actually dying in hospitals and nursing homes, as shown in the kind of pie chart distribution here. And so this means that as emergency physicians, we are often caring for people at the end of their life, right? And that means sometimes in ways that might not align with their preferences. So why do we think, again, some audience participation, why do you think there's such a discrepancy between preferred and actual place of death? What are some thoughts?
Hearing litigation.
That's very true. What
You're
else?
not the one making the decision.
Yep.
I think sometimes people get scared.
Right, like fear, right? Anyone else want to share any other things?
Thinking that you're not going to die now, so you figure this is all the current illness is temporary without realizing that the end is nigh.
Right. So a lot of people are ill prepared or in denial or actually just maybe don't even have the medical literacy to understand kind of how advanced their illness is. And so, people, which we'll get into, will cover these things, lack, planning for death, advanced directives, documented wishes. Goals of care discussions often happen very late in a patient's disease course. There's family conflict. Like I said, if it's children who are the decision makers, they all have to come to an agreement. And then system pressures as well. And so this really becomes more and more relevant to us. A lot of us are aware the baby boomers are aging and they're aging rapidly, and they're going to become the majority of, or I shouldn't say majority, but a significant portion of our emergency department volume as the years go on. They are exploding in volume, and they will be increasingly the patient population, those 65 and older, who are often dealing with chronic and serious illness, will be a large portion of who we are caring for in the emergency department. ED visits at the end of life are extremely common and often present an inflection point in the trajectory of their illness when they arrive. And so it's really important that our ED care kind of set the tone for what that means for a patient as they continue in battling kind of their serious illness and thinking about the end of their life. So in order to understand our role here a little bit more, it's important to understand how we've become so medicalized over time and how we've gotten here. So a century ago, most deaths, right, were from sudden illness. It was acute things, infection, trauma. People died pretty quickly. It was somewhat expected. There were few medical interventions. Most people did die at home. Poorer patients were kind of dumped in hospitals to die. That's, as we know, kind of the history of Bellevue. It started as a hospital for the dying poor. But, most of it was kind of natural, quick, and expected. Now that we have so many incredible medical advancements that have made so many incredible strides in the lives of people dealing with different disease processes or serious illnesses, we have patients dying at higher rates now from chronic diseases like CHF, COPD, dementia. Less so, I mean, we still obviously get patients dying from infections, but a lot of patients now in our current times are dying from chronic illness. And so while medical advances allow us to intervene in more ways and keep people alive longer, they also prolong the dying process. This is really relevant to us in the ED, right? Because we love resuscitating. We love intervening. We love doing procedures. We love saving, rescuing, bringing people back to life, keeping people alive. That's what drew many of us to emergency medicine. Our skills, our interventions are life-saving, right? We can do incredible things in medicine. But we also need to recognize when these interventions may extend suffering rather than quality of life. And so a bioethicist, Albert Johnson, who was kind of one of the founders of the field of medical ethics, described this kind of obligation to rescue in medical care, to keep providing interventions to patients, and that kind of impulse to continue to do things as the rule of rescue. It describes why we instinctively act to prolong life, even sometimes when the outcomes we know are going to be poor. And really, this moral obligation is ingrained into medical care now and the care that we provide in the ED. And so it also is exacerbated, these expectations or this obligation to rescue, by media perceptions, right? And just our culture in general of what emergency care means for patients and families, as well as for ourselves. So TV and film often depict really dramatic, heroic emergency department saves. They often show CPR as extremely successful. We know that in reality, actually, even if you get ROSC, most patients will not survive to their hospital discharge. And CPR is always performed so badly in the TV shows, right? It's like, it's not showing the kind of breaking ribs, the brutal nature of resuscitation. And so this creates unrealistic family expectations to do everything, even when it may not change outcomes or may even cause harm. Also, it's important to note that patients, particularly from vulnerable or underserved or minority populations, have a mistrust of the medical system. And so when they have a mistrust that you might not be doing everything you can to save that person, that you may have a bias, a racial bias, or a lack of care for their life compared to someone else's life. And so that also plays a role. So this is real. Like families usually expect us to do these heroic saves, especially when they come in kind of an acute presentation. But really, it's not the only, we have to consider more than just the ethical obligation we have to rescue, to save. And so I just want to kind of go over the main ethical principles that should also guide our care in situations like our opening case. So autonomy, right, is the patient's right to self-determination. In terms of caring for the seriously ill and dying, if we don't, I want you to ask yourself, if we don't know their wishes, or neither do the family, how do we respect their autonomy? How do we figure out a patient's families or patient's values from them or from their families? Beneficence is the, doing good, acting in the benefit for the patient. And so while, of course, you can consider a lot of the life-saving heroic care and interventions that we do as acting good, saving lives, how do we know when it's kind of bleeding over into causing harm? So that goes into non-maleficence, which is do no harm, avoiding unnecessary pain and suffering. Many of the interventions we do may save, but they also may cause harm. They may not align with the values that our patients have for themselves. And then finally, justice, which is treating patients equitably and fair allocation of resources. I want you to ask yourself, how does end-of-life care different
Thank you.
patient to patient? And how do disparities, bias, and access impact what a patient perceives or is able to attain for a good death?
Would you mind buzzing me in? My thing is expired. Thank you.
Someone needs to mute themselves. I'm so sorry, but okay. All right. So understanding those ethical principles help us frame why end-of-life planning matters. Okay. Majority, majority want to die at home, and majority agree that talking with their loved ones about end-of-life care is important. And majority will say that putting it in writing is important, but actually very few have actually done so. So this lack of communication creates confusion and stress for families, and places clinicians in very difficult positions during acute care. So let's talk about the three types of kind of advanced directives that New York State recognizes, that ideally patients will come in with, but many of the times they don't. So first is a living will. So a living will is a legal document that a patient writes while they're alive, and it can specify the medical preferences for their end-of-life care if they become in a position where they're unable to communicate. A healthcare proxy is different. So in a living will, you actually, in New York State, you can't designate a healthcare proxy. You need a healthcare proxy form. So a healthcare proxy is a form, a legal document that designates that you designate, or if you're unable to make that decision, well, that gets complex. But basically, it's a form that designates another person to make decisions on behalf of yourself if you're unable to do so. And then there's the DNR and DNI forms and the MOLST forms. So these are specific forms that document preferences about life-sustaining treatments. MOLST includes things like dialysis, feeding tubes, IV fluids, antibiotics, a lot more things. And this is really signed by a patient and a provider. And this is really important specifically towards the end of life or an advanced stage of diseases, that people have a MOLST form filled out so that they can, clarify what their goals are and what they would like at the end of their life. But we know, ideally this happens in an outpatient setting, but as we know, many patients, this isn't happening in an outpatient setting in a lot of cases. A lot of patients rely on RED for their kind of primary care, and so a lot of patients come in here into our EDs, into our hospital systems without these things specified. So what does that mean for patients then? So like I showed earlier, majority of patients kind of in the historical modern years are dying in the hospital. A lot of them are dying in the ICU. 60% of ICU admissions end in death. 25% of all healthcare costs go to the 6% who die every year. And we spend more on critical care than any other country. This goes against what people want in general, right? So majority want to die at home, they say, but majority have actually been dying in the hospitals, in the ICUs. This can lead to potentially costly, invasive, sometimes painful care that does not align with the wishes of a person at the end of their life. The other more common place people have died in more recent years are nursing homes or long-term care facilities. So about 25% of Americans will die in a nursing home. The first-year mortality rate for residents in a nursing home is up to 35%. Majority of nursing homes are for-profit. And we know, we all see patients come in from nursing homes and the kind of states that they're in. There's a lot of risks to living in a nursing home. Many patients develop bed sores, infections. They can die from medication errors, neglect, falls, and even abuse. So nursing homes are not a perfect place. And again, a lot of them are for profit. And then another common place patients are now dying, and actually I'll show later that more patients are dying at home, are on home hospice, okay? So home hospice can dramatically change how and where people die compared to the hospitals or nursing homes. So hospice is a specialized care for patients who are expected to live 6 months or less. It can be at home, a nursing home, or inpatient. Majority are done at home. If it's at home, families assume the responsibility for 24/7 care except for specific crisis moments. Patients on home hospice get an interdisciplinary team that focuses on comfort, symptom management, and support for caregivers. And really, when you're entering home hospice, you are not focused on curative treatments. It's really all about maximizing comfort. It's also important to note, though, that you can still come into the ER on home hospice. I know a lot of us get confused when someone comes into the ED and they're in hospice and we're like, why are they there? Patients actually still can come to the ED if families need a little bit more support, kind of managing their symptoms, or, sometimes they just get afraid at home, seeing their loved one going through kind of a crisis. But you still can come to the hospital, but ideally you're focusing 100% on comfort rather than life-sustaining treatments. We know that the benefits of hospice include fewer ED visits and hospitalizations. Some studies show that patients live longer on hospice, and hospice has been shown to reduce costs and improve satisfaction rates for patients and their families who are dying from serious illness. And most patients actually have a very positive experience with hospice. So who pays for this? I would be remiss to not talk about our system because we have such a complex kind of payment insurance system in this country. And so it's important to understand who finances end-of-life care to help us better understand some systemic barriers. And because we care for so many elderly kind of advanced stage patients, especially in the OBS unit, where placement, we have a lot of placement patients, and insurance really matters for where they're going to go. So it depends. So I should say long-term care, like nursing homes, other long-term care facilities, majority is paid for by Medicaid. Okay, this is why it's so important on OBS that patients get Medicaid before they get placed to like a long-term care facility. SAR is different, but usually if they're going to nursing home, long-term care setting, they need Medicaid. Okay. It's the largest payer for long-term services and support. It has limited eligibility, right? Like you have to make a certain lower income, and so many families end up spending down their assets in order to qualify. Many patients actually also pay for out-of-pocket care at home, or like whether it's home health aid or whatever it is, Medicaid can pay for it, but actually it doesn't cover so much, and many families actually end up taking on that cost burden. For hospice, this graph over here is showing how hospice is paid for. So Medicare is the largest payer for hospice. The Medicare hospice benefit is part of Medicare Part A, and it covers 4 levels of care completely: routine home care, continuous home care, inpatient respite care, and general inpatient hospice care. It includes nursing in moments of crises or in certain check-ins, medications, physical therapy, social and spiritual services. It covers a lot. However, it does not cover room and board at nursing homes or inpatient hospice. So if you're in hospice in a nursing home, you still need usually Medicaid to pay for that, or out of pocket. What's really important that I want to bring up, because we interact with caregivers all the time, right? Patients, especially patients with dementia, who come in with their caregivers, a huge burden emotionally, but also financially, is actually left to the caregiver. So I'm going to show a photo series that I found online about a patient dying from ALS on home hospice. And while home hospice has this beautiful idea of dying at home, it's actually a huge burden still for caregivers, because families actually assume the role of the 24/7 care that patients on home hospice usually require. In home hospice, families are the ones who administer their medications, titrate the medications, provide their daily care, manage symptoms like pain, bleeding, and breathing difficulties. This can be really, really, really hard for families, okay? One, to manage, but also to see their patients kind of in decline like this. Families who can afford it may hire aides or RNs, but most take on much of the responsibility themselves. Caregiver burnout is extremely common, and so I would just argue that we need to have a little bit more compassion when patients come in, and I know we say dump, and there's problems with dumping patients in the ED, of course, for placement, but it's really, really, really hard to care for people with advanced illness at home. And so I would just, ask you to extend the courtesy to the caregiver to recognize how much work goes into caring for someone when they bring them in, whether they want them to be placed or not. It's really, really hard. And being aware of this burden is really a critical part of our communication and our compassion when caring for patients with serious illness. There's also, like any other aspect of Medicare, there's some serious disparities in who gets to die well. And even though, like we talked about, a good death is subjective, it's personal, it's relative. Majority of patients on hospice are white. Black patients and other minority groups are less likely to receive home hospice and other access to palliative care and other end-of-life kind of services. A lot of reasons go into this. This is multifactorial. One is medical mistrust in the system. And right, like the idea that like, oh, we should focus on comfort might be perceived from a family who has some mistrust in the system as, oh, you're just giving up. You just want to, you don't want to save my family member. Their life is not as important. And so that's an important thing that goes into kind of not getting transitioned to palliative care, end of life, or home hospice at the end of patients' lives from more marginalized communities. Also, a lot of, underserved, vulnerable communities just do not have the health literacy to understand prognosis, or kind of what's going on with their patients. And then, of course, we know there's a lot of inequities in caregiving abilities, whether it's hiring someone or being able to do so at home for home hospice, as well as issues with access to insurance. So I just want to make that point that disparities exist in end-of-life care. So what is palliative care? And I'm going to wrap up really quickly, but palliative care is different. Okay, so palliative care kind of grew about 50 years ago or so, but it's rapidly expanded in the last like 20 years, I would say, because it's increasingly recognized as an important way to help patients cope with their serious and advanced illnesses, but also kind of respect their values and wishes towards the end of their life. So the goal of palliative care is to receive suffering. It's not limited to end-of-life care. Traditionally, usually palliative care got involved right at the end of life in the ICUs, and honestly in a lot of hospital systems, including ours at Kings County. Unfortunately, we don't have the resources necessarily for palliative to intervene more early, but in some other healthcare systems, like at Columbia, I did a rotation. Palliative care is seeing patients with heart failure, seeing patients with COPD, and really you're not waiting until that last moment to have those end of life or goals of care discussions. It involves aggressive and comprehensive symptom management for patients dealing with any serious illness. And it's really a focus on quality of life rather than quantity of life. There's interdisciplinary teams usually in palliative care, social workers, chaplains, lots of different people usually are on palliative care services, and it really helps support patients and families with end-of-life decision-making. An important distinction from hospice is that patients on palliative care can continue to receive curative or disease-modifying care, and that's a misconception a lot of patients may have when you bring up palliative care or a palliative care team gets involved is, oh, no, we still want to, we're not ready, they're not dying, we're not going to hospice. But really, it's not about hospice. You can still continue curative or disease-modifying care, but really it's about focusing on quality of life and values and goals for patients. We know that, like I said, so palliative care programs have exploded over the last 20 years or so, and it has kind of correlated with, now we see over the more recent years, more patients are actually starting to die at home than they are in the hospital, including on home hospice. We also know that engaging palliative care early on in a patient's disease course and not really at that end-of-life crisis moment leads to better patient and family satisfaction with the healthcare system. Patients feel more like their wishes and their beings are more valued, more heard. You can have better symptom control, reduce healthcare utilization, and cost savings. So just to wrap up, let's bring it all back to the ED. So like I said earlier, we know that in the last 6 months of life, ED visits are very, very frequent. 75% of older adults with pre-existing serious illnesses like cancers, heart failure, lung disease will visit the ED in the last 6 months of their life. So we have a really important role here, right? We are the front line of seeing patients usually in their acute phase of their serious illness, but their presentation to the ED usually marks an inflection point in their illness trajectories, right? So usually patients come in with certain quality of life, dealing with a serious illness. The moment they come to the ED or get hospitalized, they're in an acute crisis, right? Their kind of quality of life is declined in some way due to their acute illness, acute on chronic illness presentation. And then we know that their quality of life from there actually does decline further. And so while many patients are coming to the ED for acute issues, many actually, we have to recognize, have priorities other than living as long as possible. Yet if we're not talking about this with patients and families, then they're at risk of not receiving care aligned with their goals. We also know that for patients admitted to the hospital, the intensity of care determined in the ED often continues during hospitalization. And so by default, usually a lot of patients' hospitalizations, if we started in the ED, do focus on prolonging life through different interventions without necessarily emphasizing quality of life. We also know that many patients come into the ED without advanced directives, and so while they're still able to communicate their needs, it really is an important kind of opportunity to have these conversations with patients. Ideally, again, these conversations are happening prior to the ED on an outpatient basis, but we know that that doesn't happen enough. And really, like an old model, like I said before, an old model to palliative interventions was kind of really in this kind of very end of life kind of crisis moments. But now a new model that a lot of health systems are recognizing the importance of is to really get palliative involved early on, right? From the outpatient setting, and continue on there. Really, a lot of us, I know we're constrained in the ED, right? So two types of conversations about end-of-life care usually happen in the ED. Subacute, or kind of is like when patients present at some point during their more long-term decline, like whether they're coming in for dehydration or failure to thrive or whatever it may be. And really, that's an important moment where we should be having serious illness conversations with patients. It's when they're still able to kind of express their values, make decisions towards the end of their life, or at least start thinking about it. Really, when we wait, I know in the ED we're constrained a lot of times, it's towards the end of their life that we start asking kind of goals of care or values at the end of life, but it's really too late when you start to have these conversations really at the end. So we really do have a prime opportunity in the ED to start these conversations with patients who may not be getting these conversations or thought-provoking questions otherwise. This is kind of, I want to quickly, last slide, go over challenges in the ED, which is kind of redundant. All of us know it. This all sounds great. Let's all talk about, what people want at the end of their life while they're dealing with serious illness. We know that in the ED, it's actually a lot harder than that. We have minimal time, minimal space. We don't know the patients as well. We don't know their families as well. We're new to them. So these are really hard conversations to have, both on our side and from the family side. They also come in an acute presentation. And so a lot of times it's difficult for them to make that decision immediately, or think about it. And so it's while many of us feel like it's not our role in the ED or we don't have time to, there's still some serious benefits about trying to do so, right? So we know that there's studies that show that talking about goals of care or end-of-life wishes in the ED have significant cost savings, shorter hospital lengths of stay. It also improves communication, reduces stress, and mitigates risk of our burnout. So I just want to end by offering you what I think that we could do better. And I hope that this talk has at least kind of allowed you to think ethically or about, how we approach patients in their end of life and what's right for them in terms of respecting their autonomy, doing good, doing no harm, and considering justice in their care. But what you can do in the ED yourself is when a patient comes in like this, like in our case, explore the values with the son, take a values history. Don't do a menu of, do you want CPR? Do you want us to intubate? Do you want us to do central line? Talk about what's important and try to highlight what's important for the patient and for the family. Did they ever talk about where they wanted to die? Did they ever say that they hated the hospitals, they hated being hospitalized? Try to elicit what's important in a values-based history when you're trying to help a patient or family member decide what interventions are best. Also, chart review for prior directives, document their wishes. We don't have enough documentation. It's really important, especially when they're in a kind of presentation where they're seriously ill but not critically ill and can communicate what they want at the end of their life. We really should be documenting and making sure that's in the chart so that when they come in and they're not able to express that, it's clear that they've had these wishes communicated. Respect their autonomy. If a patient does not want certain things at the end of their life, respect it. They may go against what we think's best for them, but everyone's different in terms of what's important to them when they're dealing with serious illness or death, and we have to respect their autonomy. That includes respecting if a family thinks that the best thing for a patient is to keep them alive for as long as possible. I know that often we feel terrible when we have to intubate patients like this, and it feels cruel to do CPR on a lot of patients like this in our case. But if that's what the family truly feels is best for them, then we can only respect it, and we should feel good about that's what the family thinks is in line with their values and goals, and so that's what we respect. Also manage expectations. The ED is not necessarily the place where patients or a family is going to decide DNR, DNI. We shouldn't expect that, right? But we are starting the conversation by bringing these things up. We are helping them think about it before they go on into this hospitalization that doesn't reflect kind of their values. Use really plain language when a patient is dying, right? Like, or very critically ill. Say, I'm afraid they are not going to survive this hospitalization. I'm afraid they are dying. Don't be afraid to use that word. We're so afraid of using it. And then engage palliative care early. We know it has better outcomes for patients. We're starting to have that culture in the ED at Downstate because of Dr. Setz, that we are calling palliative kind of earlier on. But at other institutions that you might go into practice, palliative care is being consulted for patients who are not in the ICUs, who are not acutely dying, who are not acutely ill, and are helping patients and families kind of decide what's best for them as they look towards kind of serious illness and the end of their life. So I just hope that, ultimately, this has been a little bit thought-provoking about other considerations you should think about and ways to address these with families and patients in difficult, both kind of earlier points in a patient's illness, but also later points, and that recognize that, there's more than just rescuing patients. It's really about, respecting values, wishes, and I hope just that you think about it when we care for these patients we so often do. I'm so sorry I went over time, but, and I know we don't have much time for discussion, but that's all I have.
So just so you know, we had a lot of discussion in the chat that I didn't necessarily want to interrupt about, just about like hospice in the ED, whether that leads to revoking of hospice, and Dr. Stetz has been answering a lot of that.
Oh, great. Okay.
One of the main things that she wanted to communicate is like making a recommendation after these conversations, like making the recommendation of DNR DNI, and with the caveat that they don't necessarily have to follow your recommendation, like a lot of our cases, but that you make that recommendation as the doctor. And that these are very, distressing things for patients. Even going on hospice can be very difficult for family members. Dr. Graff also had a question.
It was answered.
It was answered? Excellent. Okay.
Okay, awesome. I didn't see any of the chat, but now I can see it again. Thank you so much, Dr. Setz, for answering all those questions. That is a point I did want to make that I don't think I did, is that, it's in other countries, like they will not offer like dialysis to like a bedbound nonverbal patient who has essentially like no quality of life, right? But in this country, we do. We just offer. And we shouldn't expect a lot of our patients or families to have the medical literacy to know what that means or to be able to then revoke it when you're offering something, right? And so I think it's okay to say, they're in renal failure. I doing more is not going to change the ultimate prognosis. So I think that's a really important point, that I think we do have an ethical responsibility to kind of share what is probably best for a patient.
This is a really
what
great
their
talk.
values are.
This is a really great talk, and I think on the floors we deal with this a ton, and it's very easy for us to get really frustrated with family who we're just like, oh, let's just do everything right. Like, let's just put the patient on dialysis who hasn't spoken in a year. Let's peg this patient. Let's trach this patient, and we really have to check our emotions at the door. And you talked about this, but I think it's really important. I think that's the biggest challenge for us is being able to say, this is crazy, but really understanding that um, try to put yourself into your into the patient's family shoes. This is their mother, this is their father, this is their family member, and it's very hard to see them at the end, and they may not be able to process all that information. But getting that conversation started is such an important part, and they might never process it. I had a patient last month on the floor who the son was a physician, and this patient ended up being trached and pegged, and so it's very it's challenging, and it's challenging to try to convince somebody to let their loved one go, even if we kind of think, or in our experience, that might be the best thing for that person. So I just realizing that you have to check your emotions at the door, try to give them the best advice to make the decision, but in the end, respect the decision that they do make.